Cost of care for common back pain conditions, chiropractic versus medical management. A recent publication in the Journal of Manipulative and Physiological Therapeutics in 2010 is entitled Cost of Care for Common Back Pain Conditions Initiated with Chiropractic Doctors versus Medical Doctor/Doctor of Osteopathy as First Physician. Experience of one Tennessee-based general health insurer. Given the call for healthcare reform and the need for data upon which to inform these decisions, this study stands out as an important example of how current large databases will be used to examine existing practices to determine future healthcare delivery design and policy. It's likely that Blue Cross Blue Shield, Medicare, and the military databases of the Departments of Defense and Veterans Administrations will serve as sources for data mining for examining how dollars are spent and how systems will be designed for future templates of how healthcare in the U.S. will be orchestrated. Blue Cross Blue Shield is comprised of at least 39 health insurance organizations and companies. It covers over 100 million Americans. These insurance companies are basically franchises independent of the association and generally each other, operating as regional or single-state companies or large multi-state groups. They act as administrators of Medicare in many states and also provide coverage for state and federal government employees under the Federal Employees Health Benefit Plan. As an example of how widespread and influential Blue Cross Blue Shield is, WellPoint, the largest Blue Cross Blue Shield member, is spread throughout 14 states and is a publicly traded company. It's clear that the Blue Cross Blue Shield influence, especially considering their role as administrators of Medicare, will likely guide future processes for payment. As usual, let's begin with a summary of the findings and then examine more closely the details of how the study was conducted. This study represents a retrospective claims analysis performed on Blue Cross Blue Shield of Tennessee's fully insured population over a 2-year period. Patients had full access to either MDs or DCs through self-referral. And it's important to note that there were no limits to the number of visits or differences in copay between the two different providers. The article begins with an overview of the context upon which this study was based. Carey et al. Reported that patients with chronic low back pain had an annual average of 21 visits to providers and an average of 2.7 provider types. Many of the tests and treatments utilized were not evidence-based. Also, there was evidence of high utilization of advanced imaging, prescription of narcotics, and multiple physical treatment visits. So given this is a comparison of the costs for MD versus DCs in managing low back pain, the burning question is, how did we compare? Well, care initiated with DCs was 40% less than that initiated with an MD. With risk adjusting, the DC care was 20% less than MD care. We will look into what risk adjusting means in the study a bit later. But first, let's look at how this study was constructed and executed to see its strengths and limitations. First, how do you select the patients? It's important to limit who the patients are so that you're clearly dealing with patients with similar problems and eventually, through risk adjusting, compensating for different degrees of severity. One way to accomplish this is to use ICD codes that include common codes used by chiropractors and MDs for low back pain. Note that this does not necessarily reflect a diagnosis. For example, if a provider uses the code for intervertebral disc disorder, we don't know whether that meant there was radiation or not, or even whether the provider thought that there was a subluxation versus a herniated disc. Using this approach, of the 669,000 members in the database, about 85,000 met the diagnostic criteria, which equals about 13% of members. Next, using current procedural terminology, CPT codes for the initial visit, identification of the initial provider could be determined. For example, coding for chiropractic manipulation would identify the chiropractor. Coding for an emergency department visit would identify an MD provider. Originating visits to either an osteopathic doctor or emergency department visit were included under MD care for cost analysis, so that all osteopathic physician visits were clustered with MD care. Therefore, the comparison was between this combined group and chiropractic care. Key to the ability to compare costs is to establish the criteria for an episode of care. To be called a new episode, the patient presentation had to meet the criteria of a clean period of 60 days. If prescription drugs were used for more than 60 days between visits, this was considered one episode even if the last visit had been more than 60 days. To eliminate any biasing of data, all patients with incomplete data were eliminated. Before making comparisons, it was important to account for the possibility that those seeking MD care may have had more severe or complicated low back pain. The researchers incorporated an accepted approach called symmetry pharmacy risk groups, which uses the following to determine severity based on pharmacy use, claims, gender, and age. By using the PRGs, individuals could be risk-adjusted across all their episodes of care. Then by using a PRG score, a risk-normalized cost could be estimated for all. So how were the costs analyzed? Both allowed costs and the paid amount were included and compared. Allowed amounts were 27% higher for MDs, and paid amounts were 39% higher for MDs. Even with risk adjusting, the paid amount to MDs was 19% higher than for DCs. Specifically, without risk adjustment, the allowed amount for DCs was about $755, whereas the MD's allowed cost per episode was over $1,000. The paid amount for DCs was on average about $450, whereas for MDs it was $740. So let's summarize. About half of the difference between the costs initiated by DC versus MD care is related to risk selection. There may be several other factors for higher MD costs other than the severity of the patient mix. MDs are conventionally paid more for similar services and even when risk-adjusted for patient presentation severity. MDs prescribe medication, which is costly. It's likely, although not evident in the data, that MDs make more use of costly special imaging. Let's be clear, this was not a study of best practices or treatment success comparison. The intention of this study was to identify not whether services were appropriate or not, but a 2-year snapshot of current management costs for medical care versus chiropractic care. In this regard, it's clear that MD cost is higher. How this is interpreted and utilized is yet to be seen. It could influence cost structuring, guideline or pay-for-performance practices, or demonstrate that without any changes to current practice, chiropractic care is more cost-effective. This is the wave of future studies using large existing databases to determine cost. Combined with other studies focusing on patient satisfaction and treatment benefit, we would hope that we were not only applauded as being more cost-effective, but in fact are considered to be the cost-effective and treatment-effective option that warrants more public exposure due to its overall value.